Good morning, ladies and gentlemen. I am Dr. J.C. Mohan, and I am chairman of Department of Cardiology, Institute of Heart and Vascular Diseases at Jaipur Golden Hospital, New Delhi. And today I am going to say a few words about heart failure with preserved ejection fraction in the young. Typically, HFpEF or heart failure with preserved ejection fraction is the domain of aging population. The mean age of patients who have HFpEF is about 72 years. Even the recent fine art study, mean age was 72. Both in Deliver and Emperor Preserved, the mean age was 72 years. Even Topcat study had 71 years as mean age. So obviously it is a disease of the elderly. However, that does not mean that heart failure with preserved ejection fraction does not occur in the young. Dr. Trump and his colleagues from Singapore defined HFpEF in the young in those individuals whose age is below 55 years. Using data from CHARM, Topcat, and iPreserve, they found that 5% of all HFpEF occurs in age below 55 years. We have looked into this aspect carefully and we have collected some data with regard to HFpEF in the young. The salient points of HFpEF in the young are Western data suggests that these patients usually are obese. Number two, they are men. Number three, they are more often black, and it also occurs quite often in Asians. We have some differences. Patients in India are somewhat different compared to this data of HFpEF in the young published by Dr. Trump and colleagues. Our patients more often have diabetes. Obesity is not an important risk factor. Pre-diabetes, hypertension, visceral obesity, and female gender are more often risk factors in our heart failure with preserved ejection fraction patients. Good number of diabetics in this country present with HFpEF, which is difficult to diagnose because resting diastolic functions are normal. Resting morphology of the left ventricle, left atria looks normal, and these are individuals wherein more sophisticated tests like left atrial strain or maybe stress diastology need to be used more often. The other important aspect of HFpEF in the young we realize is unlike the data from the Western world where natriuretic peptides are not significantly raised in these young people because of majority of these patients being obese, our patients do show diagnostic value of natriuretic peptide because our patients don't have that kind of obesity. The increase in left ventricle mass, which has been described commonly in the Western young HFpEF patient, is also not a big issue in Indian patients. So female gender is important aspect. Relatively normal body weight and BMI or slightly increased BMI is a characteristic. Raised natriuretic peptides are a characteristic, and of course diabetes is a major risk factor. That does not say that hypertension is not that often present. But we are talking of individuals who have treated hypertension. So even if they are hypertensive, hypertension is not an issue in pathogenesis of, at least seemingly it is not an issue in these patients who have that. We feel that why we have to identify this phenotype of FPEF in young Indians, because I have a definite feeling that the approach in our patients would be more often metabolic because of the relation between ectopic atrial fat and HFpEF. We may have to, it is possible that drugs like GLP-1 receptor analogs, semaglutide, or dual incretins like terzepatide, as has been shown in Summit trial by Milton Packer, may have more important role to play in HFpEF in the young. Nevertheless, this is an area where enough attention has not been paid. The National Heart Failure Registry of India does have 13% patients who have HFpEF, but these patients have not been further characterized with regard to age, with regard to risk factors. So we need to understand more about HFpEF in the young in Indians. Thank you very much.